Hi, and welcome to the show. Subscribe at KevinMD.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Dennis Hursh. He's a health law attorney. Today's KevinMD article is Are Hospital CEOs Overpaid? One Lawyer's Skeptical Take on Executive Compensation. Dennis, welcome back to the show.
No, thank you, Kevin.
So Dennis is a regular guest talking about all things physician contracts. Today we'll take a little tangent from what we normally talk about and talk about hospital executive compensation. Are hospital CEOs overpaid? One lawyer's skeptical take on executive compensation. Dennis, for those who didn't get a chance to read this article, tell us what it's about.
I got really annoyed because honestly, I was reviewing a contract for a hospital CMO. This was right after I had done a orthopedic trauma surgeon's contract review. And for an orthopedic trauma surgeon, I can tell you what the median total compensation is for a specialist employed by a Pennsylvania hospital. So we can really drill it down. I assume there's a lot of hospitals. I should get some good data for CMOs. There isn't. About the best I could do was median compensation in the Eastern United States. Then that got me curious. And I said, I'm wondering if there's a trend here. I looked and CEO compensation is the same way. Now there's over 6,100 hospitals in the United States. I suspect a huge portion of them report their physician compensation data to MGMA. And yet for some reason, there's not sufficient data to do benchmarks for hospital CEO compensation. And to me, that just tells me it's a conspiracy, that's just, you don't need to know my compensation. The physicians, sure, we'll tell the world what they're making, but what I'm making, I'm an executive, after all, I went to a year after college, so I'm an important person. I shouldn't have to disclose my compensation. As you may have noticed, the article was a bit of a rant. It just is so incredibly unfair. I mean, on a lot of specialties, I can drill down, as I said, Pennsylvania hospital, and give all kinds of data about the vacation that physicians have, all their benefits, their employment, compensation, everything else. And yet CEOs, it's just, this is the median compensation. And by the way, the median compensation for a hospital CEO in the United States, according to MGMA, is a little over $280,000. The 90th percentile is $605,000. Now, I mean, if you do any social media or read any news reports, you see about the 35 million that one hospital CEO brought down. You see all these $1 million packages. That can't possibly be being reported. That can't possibly be in those statistics. Now, I'm sure those big health systems do very full, complete reports on their physicians. But as I said, I think the C-suite, that's just that's confidential, and we don't need to report that. And that's just so incredibly wrong.
So it sounds like there is a significant information asymmetry where hospitals and medical centers, they can go so granular in terms of how much physicians are making pretty much everywhere in the country. But when physicians ask how much the executive suite is making, there's so little data to go on.
Right. And the only way that can be is when MGMA sends the survey. They obviously, a lot of them just don't answer on CEOs, and the C-suite in general. I think CMOs are at the same position. So yeah, we're happy to tell you everything granular about our physicians, but our CEO, we're just going to leave that line blank. It has to be the case. As I said, that the median compensation of a hospital CEO is not $280,000. There is just no way. There's obviously all the high end have not been reporting here.
Have you had any experience negotiating a hospital executive contract?
CMO contracts, yes, and it's a different world. It's a different world. Obviously, as a physician, you're not going to get severance. I mean, that's just assumed. It's just not something that you're entitled to. If you're really lucky, we have a 90-day termination clause. We may tell you you don't have to come in, and we will pay you your normal salary for those 90 days. I'm seeing, I think the worst, well, best, depending on who you're looking at. I saw a 2-year severance for a CMO. Very commonly, it'll be 6 months if you stay for 3 months. And after that, you go to a year's severance with full benefits and everything else. So, I mean, it's just a different world, aside from the fact the money is so much better than for a practicing physician. Then, as I said, you're in the C-suite, you're one of the boys, and we take care of our people, and just those guys in the white coats are not our people. They're just some of the workforce.
So tell us a little bit about that negotiation. So if a physician is negotiating to be part of the executive team, to be a physician executive, what's
Mhm.
the dynamics of that contract negotiation? How different is it from the typical contract negotiation that we've been discussing on this podcast?
Oh, it's radically different. I mean, nobody, first of all, I've never gotten the standard contract line for a physician executive, which I get all the time. I've probably can count on maybe at this point 2 hands in the 40 years I've been doing that a hospital really stood firm on a physician employment agreement. But I'd say 40% of the time, maybe the first thing you hear out of them is this is our standard contract. We don't change it. When you're talking the executive suite, it's always, this is a draft. What do you need? We really want you here. What's it going to take? And I mean, and incredible stuff. I've had people say I'm active in a professional society and I need to keep that. So I'm going to need, an additional 3 weeks a year on top of my vacation so that I can, maintain this leadership position. And the answer is almost always, yep, no problem. And there obviously the insurance isn't an issue, but I've had them say, "Oh, you've got a tail. You were practicing before. Of course, we'll pay your tail." And for a practicing physician, a clinical physician, you almost never get them to agree to pay your tail at the old location. Sometimes they don't want to pay your tail at this location. So it's just a different world.
Now, can you speculate as to why that is? Is it so difficult to recruit physician executives that there's such a large disparity when it comes to contract negotiations?
I honestly believe that you are now joining the club, and it's a very exclusive club, and we take care of ourselves. And then there's the workforce. There's the janitors are in our workforce. There's the ladies in the cafeteria, and we've got these folks running around in white coats that are also part of the workforce. And that's an expense that we're going to manage, but you're now in the club, so we take care of our own.
Just to give some context, so if a physician is applying for a CMO position or some type of C-suite position, what kind of premium will they receive typically on their salary, for instance?
I think I've seen one that I think was about twice what they were making as a clinical physician, and 1.5 times is pretty standard. It's just frustrating for me that what healthcare is in America is doing PowerPoints. Those folks in the white coats and the treating of patients, that's just kind of a sideline. It's we sit around and look at PowerPoints, and that's where it's at. So it's a huge premium. And as I said, the benefits are going to be so much better. I don't think I've seen a CME allowance for a CMO. It's just, of course, you will keep your CME up to date, and of course, we'll pay for that. But it just, as I said, it's a completely different world.
So what other differences are there? So you mentioned things like there's no CME allowance. Is there more paid time off, for instance? What other benefit disparities are there?
Frequently, there are. The huge one, the one that really just stunned me was that severance agreement. As I said, I have never seen a severance less than 6 months. And I've seen several where for the first 90 days, if we terminate you for cause in the first 90 days, then we're only going to give you 6 months severance. But if you make it through those 90 days, then you get a year. And I had one that we negotiated 2 years of severance. I mean, that it's just unbelievable to me. And those 2 years, she had full benefits during that period too. So, can you imagine going in as a physician? I fight to get 120 days notice, in a physician employment agreement, just so you have time to find suitable replacement employment. And then, 6 months and a year is just tossed out as That's our first offer.
Now, knowing what you know about physician executives, do you ever incorporate some of that knowledge when you negotiate regular physician contracts?
I've tried to, but it literally is just it's a different world. I mean, I for a short time after the first CMO agreement I did several years ago, for a short time after I was trying to get severance in physician employment agreements, and it just it's not going to happen. It's just, that's a different world. It's just not going to happen. As I said, it's us and them, and you're joining us when you come into the C-suite.
And is that uniform among all the different type of hospitals that you've had interactions with, community hospitals, academic medical centers, and whatnot?
Absolutely. I haven't seen any difference in doesn't matter. For profit, not for profit, community, doesn't seem to matter.
So go on in terms of what does that say about our healthcare system? That there's almost like a two-tiered system when it comes to physician executives and practicing clinical physicians.
Well, I think to me, it comes down to however this happened, somehow our physicians at the front line seem to have gotten themselves at the bottom of the totem pole. And to me, that's inconceivable. The people that are actually doing it, the healthcare system is to provide healthcare. The people that are doing it, the real experts, the people with massive amounts of training, are somehow less important than the folks sitting up in the C-suite, making big decisions about, which PowerPoint style to use and things. It's just one more instance where things are completely broken. And once again, it's completely evidence of how bad physicians are treated. It's not just, well, the healthcare industry is bad, so everybody has it rough. Everybody doesn't have it rough. The folks in the C-suite, and I've just dealt with C-suite. I'm sure, assistant vice presidents and everything else also are getting very handsome severance packages and good benefits and are just treated very differently. And think of the difference between being an executive and a practicing physician. I mean, how much call does a CEO ever take? How many times is the CEO woken up at 2 a.m. with a life and death decision? And by the way, you better be, I expect you to be in the office tomorrow again at 7, making more life and death decisions. And you may be doing that 4 or 5 days in a row where you're barely sleeping. But of course, we don't expect that to change your work schedule because that's just something you do. It's just incredible to me that the executives would have it so much better than the people on the front lines. As I said, it's completely broken system.
How did it get to be like this? Is it because executives have a background in business and clinical physicians typically don't?
I don't think that's it. I really think what it is it started with Medicare coming in and government taking care of payment. And then it started to be standardized and it started to be clear that as a physician, we have a concept of what's fair market value. We have a very strict market as to what you can be compensated for your services. When I say your services, seeing patients. But if you're employed by a health system, your services are seeing patients. So your employment is going to be pretty narrowly circumscribed by what's coming in on reimbursement. And then you got this whole separate world of this is business, though. I run a hospital, that's a business. Nobody is saying, well, the assistant vice president in charge of paper clips, this is a reasonable compensation. And it's just, if I can convince the CEO that I'm really important, then the CEO will pay me well. And the thing is, it's like that everywhere. If you don't pay me well as a CEO, I'm sure I can find another hospital that will. And it just that sort of total flexibility and whatever the market will bear has been wiped out of physician compensation.
Do you see any of this changing in the future? Is
I
there anything that clinical physicians can do to change that trajectory?
No, I think just in general, stand up for your rights. I think I also did an article on hospital splaining one time, and I think it's important that you can't sit there and say, "Well, you understand it's for our patients, so you have to do it." You're the only specialist in the health system, so you understand you've got to do 365, 24/7 call because it's for the patients. I'm not asking you, it's for your patients. And just so many physicians will say, "Oh, yeah, well, I want to take care of the patients. I guess that's what it has to be." And instead, the answer should be no, a reasonable call is 1 in 4. And I guess you're going to have to pay a locums to come in on the other ones. Don't make patient care sit on my back that I have to forego a personal life in order to provide care for the patients. There are other options. It would cost you money, but there are other options. The only option is not that I do 24/7 call 365.
We're talking to Dennis Hursh. He's a health law attorney. Today's Kevin MD article is Are Hospital CEOs Overpaid? One lawyer's skeptical take on executive compensation. Dennis, as always, will end with your take home messages with the Kevin MD audience.
Well, I think you asked what you can do. I think physicians need to start standing up and saying, in my clinical position, I just want what's reasonable. I'm not suggesting that, you should say, I want salary and come in 1 day a week. And, I want a year's severance, even though the executives are getting that. But I think it is safe to say there needs to be limits on patient contact hours. I'm not going to be working 70 hours a week to keep my charts up to date. There has to be a limit on call. I too am valuable. I spent a lot more time than you did, Mr. CEO, in school. And so I have rights as a person, and the physicians have to do that. And it has to be a pushback on the system to saying, no, patient care is not 100% on me. This system needs to provide patient care, and maybe you're going to need to spend some money, but you can't just throw it on me.
Dennis, as always, thank you so much for sharing your perspective and insight. And thanks again for coming back on the show.
No, it's my pleasure.